Hello and welcome back to the ACE-IT podcast. This is season 9, of course, where we turn science into sense. In this season, we provide 10 timely episodes with the hopes of helping listeners understand what we can learn from current research on harm reduction. And let me just say, there is so much here to learn. So, I'm glad you're with us. I'm Danielle Rudes, your host, and this is ACE-IT. Methadone maintenance treatment, or MMT, is one of the most effective ways to help people who use opioids. MMT helps to reduce the risk of not only overdose, but arrest and the transmission of blood-borne viruses like HIV and HCV. One problem, even though it is the most effective, MMT has low rates of uptake and retention, which prevents it from its full potential as a harm reduction and public health intervention. At the start of MMT, patients are required to go to the clinic every day to take their dose of methadone under supervision. There are other requirements that go with this too, like regular drug testing and meetings with counselors, for example. Once time goes on and patients continue to have negative tests for illicit opioids, then they are given take-home doses of methadone to use so they don't have to go to the clinic every day. There really are no strict regulations on how many days worth of take-home doses they can be provided, but it typically ranges from 14 to 28 days at most. Previous research has suggested that patients are dissatisfied with MMT because of the clinic's policies that give them limited access to take-home doses and the need for patients to attend the clinic either daily or almost daily. Some drug user rights groups, like the Urban Survivors Union, have even argued that this limited access is unethical and cruel. They also argue that these policies are only considered acceptable because of the powerful stigma there is against people who use opioids. Why look into this subject, though? Previously, there has been a history of ignoring the views of people who use drugs when designing substance use treatment programs and policies, and their voices and experiences need to be the center of the issue. That's why. Dr. David Frank from the Behavioral Science Training in Drug Abuse Research at NYU, New York University, Rory Myers College of Nursing, and his colleagues do just this. They conduct qualitative interviews with not only people currently on MMT, but also people who were formerly on it. People who use illegal opioids, who have never been in opioid agonist treatment, and MMT providers, buprenorphine treatment providers, and people working in government agencies that regulate MMT. They clearly covered all the bases. All of these interviews were done in New York City in 2020. In their approach to collecting data and analyzing it, the researchers used a situated theoretical approach. This approach acknowledges the positionality and power relationships that exist between a researcher, subject, and participant. Something worth mentioning. These researchers have an interesting perspective on the topic, as one of them, Dr. Frank, has personal lived experience with MMT and take-home doses. As I said, the data is qualitative interviews, meaning the data is about words, not numbers. Since this is qualitative data, the researchers used a thematic approach for analyzing it. A thematic approach just means organizing the data into categories that are meaningful based on what the study is trying to find out and what we already know from existing studies. Dr. Frank and his colleagues saw several themes in the interviews from both patients and treatment providers or government agents. Let's start by going over what the patients' experiences were in the study, starting with their experiences of the restricted access to take-home doses. Almost all of the patients who are currently using MMT or had in the past were very critical of this limited access to take-home doses and the need to go to the clinic. In fact, it was the most common complaint from them. They even often compared this restriction to being in jail or referred to it as, quote, liquid handcuffs, unquote. Patients also had a lot of anger and resentment about this and felt like their experiences weren't understood by the people in the outside world. Patients had good reasons for being critical of the limited access to take-home doses, though. By requiring them to go to the clinic every day for dosing, the patients had difficulty maintaining steady employment, attending school, and managing their daily lives. Many patients don't share with their employers or friends or family that they are using MMT. This means if they missed things or were late to work, they had to lie about why. The organizational structure of clinics that provides MMT also had a negative impact for clients. The structure was often inconsistent and hard to plan for, with long lines, a lack of communication, and changes that occurred on the spot. This means they couldn't truly plan their daily lives according to their clinic visits because they never knew how long the visit might take. In addition to this difficult to manage daily structure, clinics oftentimes wouldn't provide patients with take-home doses for life events like weddings or funerals. What do people who have quit or never been on MMT say about it? Their answers aren't much different from the patients in this study. The main reason they avoided or quit MMT was because of the need for daily attendance at a clinic. I think we're seeing a pretty common theme here among people who use drugs. Patient treatment providers and those from government agencies alike all saw another problem with access to take-home doses. Like many other things in our society, this problem was related to financial incentives. The clinics were financially disincentivized from providing patients with take-home doses. Patients said the clinics were businesses, and decisions being made about their treatment were motivated by finances, not healthcare. The treatment providers and government agents said there is a structure of financial incentives or reimbursements that is connected to clinic attendance. Now that we know, several different shareholders in MMT find take-home dose policies restrictive in several ways. Let's go over the suggestions that Dr. Frank and his colleagues have for solving the problem. The biggest and arguably the most obvious is to make programs tolerable to patients so they actually use them. Since some of the restricted policies come from the structure of the organizations and finances, part of this solution is making a reimbursement system or healthcare delivery model that supports increased take-home doses. Advocates from the Urban Survivors Union that I talked about earlier have published a methadone manifesto recommending that the requirements limiting take-home doses to patients who have long attendance records and negative drug tests be abandoned. Another solution is to make the provision of methadone similar to how it is with buprenorphine. That's another maintenance-based medication for opioids. Anyway, the two medications are regulated differently, which means providers have more options for the best take-home schedules for their patients on buprenorphine. Some patients even choose this second medication over MMT because of the better access to take-home doses. Keeping on the solution track, clinics should reconsider their policies of using random drug testing, pill or bottle count spot checks, and callbacks, which occur between visits. All of these are related to making sure patients aren't using illicit substance or diverting methadone. Even those things like urine checks are part of the federal guidelines, but there's no data to support that they actually improve relevant outcomes. The last thing Dr. Frank and colleagues suggest is more detailed and publicly available information on MMD clinics' take-home dose policies and practices. The researchers suggest that the Substance Abuse and Mental Health Services Administration, or SAMHSA, should be in charge of collecting this data on a clinic level, including how many patients receive take-home doses and what schedules they are on for it. Each clinic should also make their take-home policies more readily available, so researchers and policymakers have a better idea of what the provisions are. After going through this study by Dr. Frank, it is clear it is not very positive views in terms of MMT and take-home dosing policies from patients. There is work to do and solutions to be put in place to make sure the most effective way to help people who use opioids is reaching its full potential. Thank you for listening to the Aced It podcast. We love hearing from you. So if you have comments, topics to suggest, or some science you'd like us to cover in a future season, please write to me, Danielle Rudes at Sam Houston State University. My email is drudes@shsu.edu. And of course, thank you to the Justice Community Opioid Innovation Network, or JCOIN's Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriters, Dr. Alyssa Toman from Texas State University and Sam Houston State University doctoral student Caitlin Bauer. And a huge and heartfelt thank you to Jason Luchin and the team at Slonky LLC for their spectacular production. Tune in again soon for another episode of Aced It.